This comment got me thinking of some important and interesting pharmacokinetics and dynamics concepts that I thought I'd share. So this is part 1. But IV to oral conversion for a lot of medications is not a one-to-one. So I talked about bioavailability in my prodrug videos, and then also the video where I talked about does Ozempic interact with birth control. But IV bioavailability is 100%. Usually when dosing medications orally, it's going to be less than that. For example, metoprolol is a 1 to 2.5 IV to oral conversion. For loop diuretics, furosemide is a 1 to 2, and torsemide is a 1 to 1 actually. These are conversions that we had to memorize for our NAPLEX, our board exam. This is a very important concept, so you don't overdose a patient when converting from oral to IV, and then you don't underdose a patient when converting IV to oral. Another interesting concept is that a general rule we follow is that it takes 3 to 5 half-lives for a drug to be out of your body. It also takes 3 to 5 half-lives for a drug to obtain steady state concentration after continued dosing. A half-life is the time it takes for something to diminish by 50% or half of its initial concentration. I used this concept when I had a patient who was in trouble with a DUI because she had a drug test that flagged for nordiazepam. So nordiazepam is a metabolite of Valium, the benzodiazepine, but it's also a metabolite of chlordiazepoxide, another long-acting benzo, but it's also in the combo drug Librax for IBS. She was on Librax for her IBS. Nordiazepam can have a half-life of up to 100 or 200 hours, so technically it can be detectable even after a month after her last dose. I was a student at the time of this intervention, but I talked to her attorney about half-lives and metabolism and how it wouldn't show up on a prescription drug monitoring program because it's not a controlled substance. A couple weeks later, she sent me a letter that said, "God bless you. You spent about half an hour with myself and my attorney. I'm amazed with your knowledge and the fact that you cared. Great info. Think your advice may keep me out of the orange suit." That to this day is my favorite pharmacist intervention. I will mention that the elimination of a drug can be complex between disease states and that most drugs follow first-order kinetics. First-order kinetics mean the amount of drug eliminated during a certain period of time is directly proportional to the amount of drug in the body. One drug that follows zero-order kinetics is alcohol or ethanol. The amount of drug cleared does not change with the amount of drug or concentration in the body. The amount removed remains constant. Half-life does not really apply to zero-order kinetics. The half-life decreases with decreasing concentration. So again, half-life with first-order kinetics is constant. Another interesting concept is keeping in mind the site of action of drugs when thinking about how it's metabolized, distributed, eliminated. This concept explains why we don't use oral vancomycin for systemic infections, or why we don't use IV vancomycin for C. diff infections. Oral bioavailability of vancomycin is minimal. IV metronidazole can actually be used for some C. diff infections in certain situations because it gets into the bile. For medications for UTIs, we need the medication to be able to be excreted into the urine to get where it needs to go. This is why azithromycin is not really recommended for a UTI. It has low urine concentrations. It's not heavily renally excreted. That's also why it's not really dose adjusted. Medications that are heavily renally cleared have a risk for accumulation in ESRD or CKD patients. Dosing gets more complicated with dialysis patients because some medications are removed by dialysis and some medications aren't. We have to balance efficacy and toxicity.